and welcome to another episode of Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today, we have the pleasure of speaking with Dr. Adam DeVore, cardiologist and associate professor of medicine at Duke University School of Medicine in Durham, North Carolina. Dr. DeVore is the lead author in the CONNECT-HF trial and presented its results recently at the American College of Cardiology Scientific Sessions. Dr. DeVore, thank you for joining us today.
Thank you, Lindsay. I appreciate the opportunity.
I'll start by asking, can you please give us some context about the CONNECT-HF trial and what it was designed to look at?
Definitely. So, the problem we were trying to fix in this study is a big one. And that's that we have lots of fantastic therapies for patients with heart failure, but most of them aren't used. And so the outcomes for these patients remain, unfortunately, fairly poor, with high rates of rehospitalization and high rates of death, even after diagnosis. So we were really trying to tackle the problem of how can we improve outcomes by trying to improve adherence to guideline-directed medical therapy for heart failure.
What were some of the highlights of this study?
Yeah, so there's a lot of information about which medicines to use for these patients, but there are very little data about how to actually implement a new medicine into practice. And so we wanted to study that. And instead of just kind of taking on a quality improvement program, we decided to do this through a randomized controlled trial. So we randomized 161 hospitals in the United States. And we were really trying to test an intervention that was based around two things. One is audit and feedback, so getting feedback on the type of care that you're giving. And then the second one was pairing that with education around best practices within a heart failure. So we designed this intervention. We met with half of the hospitals, and the other hospitals got randomized to usual care. And then enrolled 5,400 patients over 3 years and followed them for at least a year to follow both their changes in care over that time and as well as their outcomes.
What were some major gaps or continued gaps in HF care that were identified from this study?
So the main findings were that, unfortunately, patients continue to not be treated with most of the guideline-directed medical therapy. And I can give you some numbers around that. The primary endpoints of the trial were two of them. The first co-primary endpoint was around heart failure, rehospitalization, or all-cause death. And unfortunately, there was really no difference between the hospitals that got randomized to the intervention or the ones that were randomized to usual care. And so it didn't seem like, trying to use these features, audit and feedback and education, could help improve care to the point where we could improve patients' outcomes. But the second part of that was around what you're asking, like, what about the care being provided? So we came up with a score where we looked at the number of opportunities a patient would have to receive the appropriate medical therapy for care. That also included other things outside of medicines, like, are they going to cardiac rehab? Have they been prescribed defibrillators? Other things besides just medicines, but the bulk of that was around medicines. And we found that the patients being discharged from hospitals in the usual care arm, their scores were around 45% of the time they were getting the guideline-directed medical care, and 42% in the intervention arm. So less than half of the time they're getting the care that's being recommended for them. And after 12 months of follow-up, this intensive intervention, lots of people trying to help, lots of data coming back to the hospitals, we saw very little change. It went up by 2% in the intervention and 1% in the usual care group, or went down by 1% in the usual care group. And so there was, some movement in the right direction, but not nearly what we were hoping to see. And that difference did not end up being statistically significant. So we still see these continued gaps in care despite all the different things that we tried in the study.
What are some implications of the trial for the care of HF patients?
Yeah, I think there are probably maybe three main takeaways from this. One is that we still have a lot of work to do to try to figure out how to deliver high quality care for patients with heart failure. And there are a lot of reasons for that. We can get into that if you like. But I think just a lot of challenges to delivering best care for these patients. And this study underscores that again. The second thing, and I think this is, an important thing to keep in mind for all of us, is that most of the quality improvement programs, especially in the United States, are based around hospitals. A lot of times they're organized around trying to prevent readmissions. And so our intervention tried to utilize that infrastructure that already exists in most hospitals, especially in the United States. And trying to build upon that didn't work. And so I think it is a wake-up call to go back and say, like, well, what exactly are we doing? A lot of hospitals are investing a lot of resources. A lot of people are spending a lot of time and effort trying to improve care, and maybe taking another look and saying, like, is this really having the impact that we want it to? Because when we tried to extend it, it didn't get better. So I think that's the kind of the second lesson of, like, well, what's the stuff we're doing now? Is this really working? And the third is, I think we need to get creative about how are we really going to try to tackle this problem. And so, at least the way I look at this study, pouring more resources into the hospital-based quality improvement programs didn't seem to fix the problem. But when you take a step back, most of the care these patients receive is in the clinic. Most of the time they spend is at home. And so maybe we need to be thinking about interventions that can be delivered there, whether that's through digital interventions like apps, or things where we can engage patients in their own home setting, or do we need to think about other things that are more clinic-based as the more hospital-based? I think that's where we need to start using some creativity and testing other concepts besides what we're doing today.
And finally, a lot has happened just in the past couple of years in HF prevention and treatment, particularly in heart failure and reduced ejection fraction. Any indication that these developments can impact the care of acute heart failure patients in any way?
Yeah, I think that's the silver lining here. The good news is that we do have a lot of new therapies for these patients, and some of them have been studied specifically. We did one trial called Pioneer HF, where we looked at patients being randomized to sacubitril valsartan versus an ACE inhibitor. They're in the hospital, right, to try to improve their outcomes right as they're leaving, and showed that was a strategy that was that could improve outcomes. So I think there are a lot of emerging data of how to do this. The other part of this is that a lot of patients, you alluded to this, have a low ejection fraction, but there are a lot, and this population is growing, that still have a preserved ejection fraction. And at least it sounds like there's some preliminary news that over the summer, we're going to hear more and more that there might be new therapies for them. So that's exciting. But we're going to have to figure out the same thing. How do we figure out those patients who've recently been hospitalized? How do we actually implement this care into practice? So there's still a lot of work left to do.
Thank you so much, Dr. DeVore, for your time and expertise, and to all of those who are listening.
Thank you. I really enjoyed it and appreciate the opportunity.
If you have any questions or you have any feedback on topics that you would like to discuss in future episodes, we would love to hear from you. You can email us at info@cardiometabolichealth.org. Thank you, and until next time.